afternoon, and welcome to today's webinar, Introduction to Eating Disorders with Lori Kehoe. If you are here and you need continuing education credits, please drop your full name in the chat with the CE that you are in need of. At the end of this webinar, a general survey will be sent out to everyone so you can let us know how we're doing. And for those that need CE, you will also receive a separate brief survey so that you can attain your CE credits, and I'll get a certificate over to you after I receive your results. So with us today is Lori Kehoe, and she holds a master's degree in clinical mental health counseling. She also has 10 years of experience working in eating disorder residential treatment in various positions, including leadership roles across the care continuum. As Director of Eating Disorder Services for Sanford Behavioral Health, she participates in program development, staff professional development, program operations, developing and maintaining relationships with the community, and providing educational opportunities for clinical and non-clinical audiences. Lori loves all things theater, musicals, and opera. She told me a little bit earlier she actually does sing too, and she loves attending plays and productions. Additionally, she enjoys creating jewelry as her alternative creative outlet. Lori says, "My calling is to collaborate with a team of dedicated professionals to educate our community and to be a trusted resource. Furthermore, all of my efforts aim to eradicate the stigma associated with mental health and substance use disorders. I want to change the mindset so that ultimately the common belief is that seeking treatment is tied to strength." Welcome, Lori.
Oh, thank you. Thank you so much. I'm going to share my screen while I talk for a second. Like Kristen said, I've been in the residential and PHP and IOP levels of care for 10 years. Prior to that, though, I was an educator. So I taught high school English, and I taught middle school reading. And that is really what spurred me to my next step of getting my master's degree in clinical mental health counseling, because I could see firsthand the devastating effects of stigma, of seeking help, and how we really do need to continue to educate families, our community segments, about mental health issues and substance use disorder issues, because the earlier that we can intercede and intervene, the better chance of lifelong recovery for our community members, and especially our young people. And they're really my focus. I do get out to the school districts and try to create awareness through staff development, parent night, and also speaking in front of the students. So I'm really excited to have all of you here today. I like to start out where we usually finish a webinar with, what are your questions coming into this webinar today? You can feel free to unmute and just ask the question, or you can put it in the chat and we can answer it at the end of the webinar, whichever you choose. But I'm a very informal presenter, and so I welcome interactive.
Hi, I'm Tracy. I'm at Reach for Recovery. We, from time to time, will get clients who have co-occurring disorders, one of them being, of course, eating disorders. So I'm intrigued by how these two relate to each other. They're similar yet different. And I have actually been through this program before, but always willing to learn more information. And like I said, just looking to see how they're related, but not.
Great question, and great topic to talk about, because in my 10 years, what I've seen is that there is a great deal of crossover between eating disorders and substance use disorders. There's a statistic that says that 35% of those suffering with SUD also have an eating disorder or disordered eating. On the flip side, it's said that 55% of those that have eating disorder diagnoses also have a co-occurring substance use disorder, whether it's active or inactive. That they tend to go together very, very well, because they act in the brain very similarly, and they're attached to mental health diagnoses like OCD, anxiety, depression, etc., that really lend themselves, and especially trauma. We're going to talk a little bit more about that today. So we're going to go through some of the very general facts about what eating disorders are, who they affect, the biopsychosocial factors that influence an eating disorder. And again, you're going to see a lot of carryover. What influences an eating disorder can also influence mental health diagnoses and substance use disorder diagnoses. The truth and myths about eating disorders, signs and symptoms, typical types of eating disorders that we see, and some really good facts around those. Really important to me to really go over the health consequences that can occur very rapidly at the onset of an eating disorder or disordered eating, what treatment looks like, where you can find treatment. And I have a slew of resources for you and videos that you can share with your clients, your families, whomever you work with, your staff. You're free to take this presentation and dissect it and utilize it however you'd like after today. I wanted to gather as much information for you that you could begin to use right away. So I always start my presentations with what many of us, when we went to graduate school to get our mental health counseling licensure, we talked about the iceberg. And so, when we're looking at a client, my belief is that we look at the whole person. And my belief in treatment is that you treat the whole person. So it's often thought that we ought to treat, the substance use disorder in this area and then treat the eating disorder over here. And while it's important to have detoxification complete, I do believe you can do the residential PHP and IOP levels of care integratively. But when we look at our client, what we see are those behaviors and those symptoms of eating disorders or substance use disorder or both, and they're on the surface. But in order to do really, really effective treatment, we've got to go underneath the surface, and we've got to see what the whole person looks like. So what their mental health diagnoses are. Have they experienced grief and loss, especially after the pandemic? We now know that, grief and loss is a very serious mental health issue. And so now we have prolonged grief and loss as a diagnosis in the DSM-5. And we look at abuse, adverse childhood experiences, mental health challenges. We look at the whole person. What are some of their medical issues? And so then looking holistically as a treatment team. And if you work on an outpatient basis, what I'm going to throw out there is that I'm also seeing that you can still work as a treatment team with all of your clients' providers, so that you're not on an island alone trying to treat the whole person all by yourself. And so an eating disorder is defined as a severe mental health and medical illness. It is related to disturbances in eating behaviors, but also, and I think more importantly, the thoughts and feelings related to one's feeding themselves or malnourishing themselves. And so the most common types of eating disorders are anorexia, bulimia nervosa, binge eating disorder, orthorexia, and ARFID. And we're going to go through what each of those are. One of the most important things I want you to remember today is that most people that have an eating disorder, whether they've received a diagnosis or not, you would not know they have an eating disorder. Only 6% of the 28.8 million people in America who have a diagnosis of eating disorder are medically considered underweight. So the stereotypical person with an eating disorder, obviously it's female in their 20s, very thin, and probably Caucasian. But that is a myth. That is a myth. 60% of all eating disorders globally are binge eating disorder. And there are many, many reasons for that. Binge eating disorder can come from a lot of reasons. But it's the most judged of all eating disorders. People are very judgmental of people, obviously, in larger bodies, and also people who seem to lack control in food intake. And that's also a myth, that they can control the binge eating episodes. And we'll go through that a little bit more. But again, some statistics, some facts. Eating disorders do not discriminate. It's really, especially after the pandemic, and we know that mental health issues are on the rise, substance use issues are on the rise. We're also seeing eating disorders expanding through community populations. So it's no longer that it's just a female disease. It's genderless. So we have a lot more men coming forward, and we even see eating disorders in young boys as young as age 5. And again, there are many influences and reasons for those. Again, 28.8 million, I think it's a little bit more than that now, are struggling with eating disorders. 26% of that 28 million attempt suicide. So you can see what a mental health crisis this is. It not only takes over all the body systems and your brain development and brain function, but it takes over your life. It's an isolative disease. It's a disease of denial, very similar to substance use disorder. And again, less than 6% are medically underweight. 9% of the world population, if you figure out that number, you see, wow, that's a lot of people. And again, I stress that most people with an ED, you wouldn't know it, and they're very good at hiding it. So like I said, many people that suffer from an eating disorder look very healthy, but actually inside, medically and cognitively, they're very, very ill. And we always want to stress to our clients and families that families are not to blame. There are influences that infiltrate our families because of our strong diet culture and our strong societal overvaluing of our appearance and what we need to do to be acceptable appearance-wise. But families, when it comes down to it, are not to blame. And education and awareness is really going to help those families and support them. An eating disorder is a health crisis, and it impacts us and our families. And eating disorders are not choices. People do choose the behaviors because they are serving a purpose, just like substance use disorder or sometimes mental health behavioral issues that arise from anxiety, depression, OCD, etc. And so it's, you know, it's much more complex than just labeling it as something that, you know, we have a choice over. It's very fascinating because in the last couple of years, we've been given more funding for more research. Eating disorder has probably been given the least amount of research dollars, but we're starting to get more, and we're starting to really be able to put more effort into understanding how complex an eating disorder is. And we've come to find out, especially researching the neurobiology of people with eating disorders, that genes do sometimes play a part. So it's not only environment, but they don't predict if someone will develop an eating disorder. And again, I can't stress enough, early detection and intervention is so crucial. A lot of people that don't treat eating disorders on a regular basis may be afraid to treat it. I say again, bring in your friends, your colleagues, and let them support you in doing that. Many clinicians feel that they're not prepared to deal with trauma. I would challenge that. I would say that probably most of your clients have trauma of some type, and you're already helping them learn how to heal themselves from the trauma. So I would encourage you to learn as much as you can about eating disorders, and then rely on your eating disorder treatment professionals to help guide you. And then as you keep learning, you'll feel more confident with that. And so I like to break it down into the biological, psychological, and social factors that can be a long list of combinations of influences that help the person develop an eating disorder alongside their other mental health issues. So we look at the family history. We look at a history of dieting with mom, dad, siblings. What is the culture in the family? What are the discussions? What kind of conversations does the family have around how they nourish their bodies and how they feel about food, how they feel about their bodies? Does the person have type 1 diabetes? You can imagine that a person with diabetes has such a risk of having an eating disorder because they have been put on a diet already. They have been told to restrict from certain foods. They are constantly having to monitor and think about food and their blood sugar. And again, the genetic predisposition. I think most importantly, the next two, the psychological aspects. Does the person have low self-esteem? What is the relationship they have with themselves and with their loved ones? Do they have feelings of inadequacy, depression, anxiety, fear, and loneliness? Again, this disease lives in loneliness, and it is part of our humanity to want to be connected to others. When we don't feel accepted in our societal group, whether we're in school or at work or in our communities, we begin, I think, naturally to think, well, what do I need to change to be more attractive, accepted, and connected to others? I want to be part of my tribe. I want to be part of a group. And so then we go to the social factors that I think really, really draw us in to unhealthy and harmful habits that become eating disorders, substance use disorders, and mental health issues. So again, our culture overvalues physical appearance. Where does that come from? Social media, right? Social media can be one of the most powerful, positive tools, but it can be one of the most powerfully damaging tools to all of us. We can find anything we're looking for, and most of what we see when we're scrolling through Instagram, Facebook, TikTok, even our live streaming, our movies, everything tells us how we need to look. And if we don't like the way we look, what diet we could be on in order to look the way we look. You can get a shot now, right, to suppress your appetite and lose weight. It's readily available. There are compound pharmacies that are making it because it's so hard for the general population to get supply of. That just tells you how many people are seeking weight loss in an attempt not just to be healthier, but to feel more attractive, more accepted. And so body dissatisfaction is a major issue in our country. One of the movements that I really want to try to get out there is that we were all meant to look different. We were all meant to have different body types, different body shapes, different skin color, different hair color, different preferences for our clothing. And somehow there has to be a way. I'm just, racking my brain every day. How can we get across to people, especially our young people, that individuality should be the most popular thing to be? And that the way you are is absolutely perfect. And the least interesting thing about you is how you look. It's how you feel. It's what you believe in. It's your purpose. It's using your talents. It's doing good work in the world, and sharing joy. So again, with the overvaluing of an ideal body type, and that's for male identified, female identified, young people, middle-aged women. I even think about people in going through menopause, women who are going through the season of their change of life, how many women develop eating disorders because what is happening to their bodies? Their bodies are changing. So lot of issues that we could talk about all day long. I'm going to try to narrow it in. And so observing someone from the outside, some of the warning signs could be that you notice a drastic weight loss, but you could also notice a drastic weight gain. But it may not be that at all. Again, you may not notice it, but you may notice that the person is dieting. And more importantly, that they seem to have a need to control the food and that it's a primary concern, and that their rules and patterns seem to be right alongside an eating disorder. And the rules and patterns the list tends to grow as time goes on. But that's their primary concern. And food rituals. Again, withdrawing from social events, being with family, even eating at the table, canceling lunches. You wonder why one of your friends maybe never shows up for dinner or cancels at the last minute, and you kind of notice that things are changing, their mood is changing. If you're living with a person that has an eating disorder, or you work closely with a person that has an eating disorder, you will notice mood swings. Think about the last time you had to fast for like blood work or a surgery, and maybe you had to go 24 hours, maybe not even. How did you feel? How did you feel physically? How did you feel mentally? And so can you imagine the way that it will interfere with your brain function and your mood if you go days and weeks without proper nourishment in your body and proper fluid intake? So again, you will notice, you might notice weight changes, but a common complaint is stomach issues. And so when we think about our brain, and then we think about our gastrointestinal system, it's thought that the gastrointestinal system is our second brain. And that's why the majority of our immune system lives in our gastrointestinal system. So immediately, the body starts to say, wait a minute, you're not feeding me properly. And the body systems begin to break down. Especially if you have an eating disorder such as bulimia nervosa. And we'll go through that and I'll explain more. And so again, the electrolyte levels are starting to go up and down. All of the systems are starting to get out of balance, difficulty concentrating, difficulty sleeping. Again, if you've ever tried to go to bed hungry, it's hard to go to sleep and it's hard to stay asleep. So you can see how that will interfere also with brain function. And then we can begin to see dental issues, skin issues, hair will begin to fall out, nails will become very brittle, teeth will become very brittle. So not only from the malnourishment will there be these issues, but when you factor in then the behavior of purging, whether by vomiting, and so on, you can see how that will also break down the teeth structure. I'm not going to go through this video, but I'm including all of these videos so that you can use them. They're like 7-minute videos, but they can help you have those conversations with your clients, with your patients, with their families. These are really great tools. NIDA is a fabulous resource for you. They also have a wonderful parent toolkit. So I'll refer to their website at the end, but this is where you can get a lot of these videos. So the medical complications, I think we do have one healthcare provider here today, don't we? But the medical consequences from an eating disorder can happen very quickly. This is one of the reasons we do have to act quick. When we suspect that someone we work with may have an eating disorder, we want to refer them for an assessment. NIDA.org does have a short questionnaire that you might be able to give to your client. But I would definitely say refer them to someone like Sanford who can give them a free assessment and can help alongside you diagnose whether or not they have an eating disorder and what level of treatment they might need. But we see the cardiovascular issues, the gastrointestinal issues, the neurological issues, and the endocrine issues quickly become acute. Again, the body, it's here to take care of us, and it does heal itself, but it has to have nourishment. And our bodies can't just live on protein. It can't just live on carbohydrates. It can't just live on fat. It needs a balance of nutrition. And so our bodies can break down. And it's very sad because a lot of the people that I've seen over the years that came in with eating disorders that were very sick, that were considered terminal, had only had an eating disorder for maybe 5 years. It's just, there is a point of no return. And that's why we want to intervene as quickly as we can. And it's about changing the mindset. It's about changing those thoughts and feelings around how one nourishes their body and how they feel about food and how they feel about their bodies. And again, it's often very much started by a childhood trauma. We can't forget too that food insecurity is a major issue in our world. That alone can incite an eating disorder, a binge eating disorder. And so that's why when we sit back and take the judgment out of certain types of eating disorder diagnoses, when we look at the whole person, their iceberg, we can connect the dots and say, yep, we can see what happened before you started thinking and feeling this way about food and your body. And so again, there are many types of eating disorders. It would take us, all day to go through all of them. But at Sanford, we do treat anorexia nervosa, bulimia nervosa, binge eating disorder. Other specified eating disorder is when their behaviors and symptoms do not fit into the DSM-5 categories for those specific primary eating disorder diagnoses, but they do fit in an OSFED eating disorder diagnosis, so we can still give them the care that they need. Avoidant restrictive food intake disorder is a very complex eating disorder, and it often begins in young children, especially with autism spectrum disorder. And we know that that is a very complex and broad diagnosis that takes time to really give proper care to. So when we see, teenagers that present with ARFID, it's completely developed into something that is very difficult to change. So again, pulling together all of our resources, our medical, our psychiatric, our dietitians, ASD professionals that can really help us. And so then orthorexia, of course, is pretty rampant. We see it more often in athletes, gymnasts, those that are in the ballet, those that are in professional dance. And if you can imagine, and this is not to put judgment on any area where our kids get to learn how to be a team player, how to learn, another talent and really be able to enjoy that. But when we think about the pressure that some in our society put on our very, very young ones to start their sports careers, their dance careers, and the rigorous training that is involved with that, how are we feeding them? How are we nourishing them? And how are we helping their bodies to develop and grow at the proper rate? I'm just going to go through these really quickly, but yes, anorexia nervosa is simply characterized by self-starvation, long periods of self-starvation. But what's most important about it is the obsession with the weight, obsession with weight gain, restricting food intake. The one thing that you will always see with an anorexia nervosa patient is they do not see the detriment to their physical health and their psychological health. They do not see that it is impacting their lives. They are in complete denial. And they often have body dysmorphia, which is a psychiatric issue, and it is very difficult to treat. But when we look at the anorexic brain in brain scans, they look very similar to those who have had substance use disorder for a prolonged period of time. There is a reduction in volume of brain mass. And we kind of, we kind of call it a term that is not clinical, but we call it crunchy brain. When we see people come in for treatment who have starved themselves for so long, they can't think straight, they can't remember. It's like their brain function has gone to 10%. And so over the course of 30 days of them being in residential treatment, it's amazing what nourishing the body and the brain, we begin to see these people, their personalities come out again. And it's just amazing. Just by giving them food and vitamins and supplements, because we do take their labs, we know where they're deficient. So just improving their medical health. It's really amazing to see. So bulimia nervosa it's periods of restriction, but it's periods of binge eating episodes followed by compensatory behaviors. So when I mentioned purging could either be vomiting, using laxatives, using diuretics, using excessive exercise, or a combination of those methods to counteract the effects of the binge eating episode. This is in over the time that I've talked to medical professionals the past, especially 5 years, they really talk about how deadly this specific eating disorder is. When you think about consuming food and then immediately getting rid of it or using other methods to get rid of it, you can imagine what that does to your body systems and the damage that it can do. It can lead to cardiac arrest very quickly. And so it's just, I'm not as eloquent because I'm not a doctor, but when doctors talk about the devastating effects and how deadly an eating disorder is, I think this one is one of the top. Again, binge eating disorder, 60% of all eating disorders present with binge eating disorder. Again, it's the most judged, but again, we really got to look at what are the reasons behind it? What are the influencing factors behind it? I encourage everyone to add to your initial assessments when you bring in a patient, even if you're in the medical field, to go ahead and give a PTSD assessment. You can also give the ACEs questionnaire, but it's really good to get that information. It's hard to talk about it in the first, client session, but keep in mind, your client doesn't have to tell you what that trauma was. They don't have to retell it, but if they can tell you there was one and how it's affected them today, you have a starting point to deal with their trauma and probably better deal with their eating disorder. Again, this breaks this down for you that you can have for reference later. Avoidant restrictive. Again, you're going to see a list of preferred foods, like I will only eat broccoli and chicken. I will only eat between 10 and 2. And, I would never eat a banana. I won't, I don't eat any sugar. A list of patterns, rituals, very selective, picky eating. What ends up happening over time is that the person's list of preferred foods gets smaller and smaller and smaller. And so you can see less nourishment in the body. I'll just quickly go over the levels of care. Most of you already know all of this, but again, you can share this with people in your community that don't know. Our intensive outpatient level of care is probably the most popular today, where it's 3 days a week, 3 hours at a time. But when we assess our patients for an eating disorder, they may need to go inpatient to stabilize them medically. So then they can step down to a residential level of care, which is the next step in stabilizing the client, stabilizing their medical health. It is a 24/7 nursing setting. But what it also does, it helps interrupt the eating disorder behaviors so that the person has 24/7 meal support. They have a dietitian working with them every day. They have a clinician working with them every day, a psychiatrist. Their labs are being drawn. The medications that they need are being distributed. So it's a very important, I would say, 30 to 60 day level of care. And of course, for more acute patients, it's going to be longer. But then they can step down into the partial hospitalization level of care, which is like a full-time job. This is where the real work comes in. This is where the real behavioral modification change begins. It's where you really get to live in your life and practice and go back to your day treatment and continue to develop those helpful habits that replace the harmful habits and harmful behavior, and the harmful thoughts become helpful thoughts. And then they can go down into the intensive outpatient. Now, some people, it is appropriate for them to go directly to IOP, and that's fine. We can always look at them through that IOP level of care, and if they need a higher level of care, we can step them up. And then, of course, they come back to us in their outpatient care, to their dietitian, their individual therapist, their psychiatrist, their support groups, which we have wonderful national support groups for families and for those suffering from an eating disorder and co-occurring issues. I would highly recommend that you become part of IADEP, which is the International Association of Eating Disorder Professionals. It's a place where you can become a certified eating disorder professional if you are a licensed or certified healthcare provider or mental health provider. It's a great way to learn. And so I'm going to kind of go through, the treatment modalities that I personally endorse, that I believe are the most effective in dealing with an eating disorder, are DBT, but I like to mix DBT with acceptance and commitment therapy. It's so difficult when you're trying, think about all of us. When was the last time you tried to make a change in your life, and how difficult was that? I know change is hard for all of us. So when you think about looking at the whole person, looking at their iceberg, not only do I want to help them change the behaviors and the thoughts and the feelings, but I want them to have some kind of an anchor to hold on to, because treatment is difficult and change is difficult. And especially with an eating disorder, if you have it mixed in with trauma and substance use disorder, that when we look at acceptance and commitment therapy, we have to identify our values. And if we can identify as a patient what is the most important thing in our life, a list of our values, that may better anchor us and give us commitment to taking those action steps that are every day and maybe grueling toward our full and lasting recovery. I also don't want to discount the fact that a lot of our patients' relationships with others and themselves are not so good. And again, being able to look at our values and say, this is the kind of relationship I want to be in with this person and myself. These are the things I want to focus on. And my eating disorder, my substance use disorder, the behaviors don't align with my values. These behaviors align with my values. So this is what I want to do. So it really helps the client to make these personal choices and to give them ownership, instead of us telling them, well, here's a distress tolerance skill. Now you do it. There has to be meaning before they can do it. That's my personal clinical opinion. And then the Hayes health at every size, I bring this out because it is sort of an overarching theme that we like to look at. The reason I do appreciate health at every size is that it helps the client look at, self-respect and respect for others, but also being critically aware of the messages that we get from society. For example, one of the things I'll challenge you to do in your spare time is look up the origin of the BMI. And keep in mind that the BMI is used for most of us as an indicator of our health. It wasn't meant to be that. And so we're trying to educate the community about you can live in a larger body. You can live in a larger body and be healthy and happy and vibrant. So that's between you and your doctor. But the BMI, we have to challenge some of these societal norms that say this categorizes you as healthy or not. And also that we have compassionate self-care, that we really learn how to take care of ourselves. What does that mean? Is dieting taking care of ourselves? What about enjoying moving our bodies, doing things? Our bodies were designed to give us a lot of joy in life, dancing, walking, being with people, going to concerts, just being in life. And so valuing that as far as the ability of our body to serve us, to heal itself and to keep us in a life of purpose and joy. So those are just some of the things that we like to focus on. There's also another organization that is called Weight Inclusivity. And so breaking down the barriers of stigma and how we treat people in different size bodies. And again, my focus of trying to somehow get the message out that, again, we are all meant to look different. We're all meant to look different. And we're all meant to be able to be vibrant and happy and purposeful. So here's another video that I won't share with you today, but I do encourage you to go look at it after our talk today. It's called The Problem with Poodle Science. And in summary, it's illustrating what I just said. So if you think in terms of all the different breeds of dogs that we have in the world, and they all look different, but say that the poodle is the preferred dog type, the preferred body type, the preferred look. If I'm in a golden retriever body and I want to look like a poodle, am I going to be able to look like a poodle? I might starve myself thinking I'm going to look like the poodle, who's very svelte and, but at the end of the day, I'm going to be a starved golden retriever because I can't be a poodle. So that's a really good video for you to share, especially with young people, to really elaborate on how we're all supposed to be different. And then you all know what DBT is. I just want to share some resources with you that you could easily print out if you want to share with families, and just some examples of how we might use different DBT skill use in different situations when we're with our clients who have an eating disorder to interrupt that behavior. And then, of course, breaking down the acceptance and commitment therapy. And I gave you a copy of the Hexaflex. I love to use this version. It's just easy to look at. At the end of the day, I always tell clients, we're all of us are in the same boat. We're all trying to learn psychological flexibility. So you're not alone. So I think, again, I think ACT is a very universal thing that we all can use. But here is a list of diagnostic tools that you might look into. And one of my favorite websites and favorite organizations is feast.org. And it is a family-led organization. You can find out everything and anything you want to know about eating disorders for any age group. And there's so many family support links on there, resources, but this is a list of all of the diagnostic tools that we have access to. The one that we currently use is the EDEQ. I also really like the eating disorder inventory, because the EDEQ examines eating disorder behaviors, whereas the eating disorder inventory examines eating disorder cognition. And we know that we have to get to the cognition, not just the behaviors. And again, here is an EDEQ screening tool example for you. I'm going to go through the resources really quickly because I do want to make sure you have some time to ask more questions. NEDA, again, a great resource for you, a great resource for your families and those who are in recovery for eating disorder. Great organization. Another video that you can share. Here's the resource for Feast. Here's another, just another doctor talking about her work with young people with eating disorders. I think it's just really good to hear from other doctors, their feelings and opinions. And ANAD, I really like them. They offer free support groups. They are peer-led, but they put their peer group facilitators through a lot of training. They do have to be in recovery, I believe, for over 2 years. But they also really lead the way on a lot of research, and they have a crisis hotline. In addition, they will help you find an eating disorder therapist, a dietitian in your area if you're having trouble finding resources. Again, here's IADEP and how you can connect with them if you'd like to get their training or if you just like to get more information. They also offer case consultations on a regular basis that you could bring your cases to when you need a little bit more supervision. And the Academy for Eating Disorders, they're really leading the way for more development of research. And so I really appreciate the work that they do. And again, I'll recommend you back to feast.org. 3 books that I referenced. You probably already have most of them. These are our 2 little Bibles. I love the treatment planner guide. I buy them for all kinds of different community members because it's in line with what the insurance companies want us to, that they understand the language of the Wiley text. But also what I really love is that you can help young clinicians to write comprehensive treatment plans based on the different long-term goals and short-term goals. You can write your comprehensive treatment plans for PTSD, eating disorder, whatever that diagnosis is, all the mental health diagnoses they have, and put together a really solid treatment plan. And then I really like these 3 books. I really have followed Dr. Dan Siegel for a long time, and I think he has made probably the most impact on me in terms of understanding the brain, understanding how important it is for us to really intervene with young people if they have substance use, eating disorder, mental health issues. He explains how quickly the brain is required to learn and process information, especially as a teenager, what's happening in the teen brain. So I recommend that you get Brainstorm. It's a book that he wrote with one of his own children. It's a great way to help young people. It's a workbook, and it helps young people make decisions on using helpful habits instead of harmful habits and getting to kind of the root cause of some of the things they're dealing with, especially peer pressure. And then, of course, a lot of us work with our clients up here, and we've also got to work on how the body keeps the score. And so if we can incorporate some somatic work, I highly recommend Dr. Ariel Schwartz if you'd like to do some trauma training. You can also see her on Facebook. She wrote, I should have brought these out before, but she wrote a comprehensive treatment manual for PTSD, but she does an integrative approach with neuropsychotherapy. And so she uses a lot of somatic, you don't always have to use EMDR, but she uses a combination of CBT and EMDR, but not the EMDR that would take you months and months and months. It's really helping clear the trauma and the adverse experiences out of the body, helping calm the nervous system, how to help the body and the brain work together and heal together. So I offer those resources to you. And also Dr. Frank Anderson. I don't have a slide of him down, but Dr. Frank Anderson does a great 12-module training on how to use internal family systems to deal with trauma. And I think he and Dr. Ariel Schwartz have a good combination there. really, really fascinating things that are coming out that are really going to help our clients toward full recovery, to help give them the tools that they need, that they can use instantly. You know, a lot of our somatic work, calming, you know, you can use tapping. Many of you already know about that. That's something you can do immediately with your clients. Doesn't cost money, doesn't require any equipment, and it can already in a minute begin to calm and reset the nervous system and help the body and brain heal. So I'm open for questions. I threw a lot out at you today, and I hope it was helpful, but I'm always available at some other time to have a discussion.
Well, thank you, Lori. We do have several questions in the chat. So if you want to go ahead and unshare your screen so we can see your beautiful visage. Awesome. So Carly has a question, and she asked, what trends and updates are you seeing in the diagnosis of orthorexia nervosa?
Again, it's, you know, you're looking at, look at our culture. Are you thinking in terms of what I'm seeing or in terms of treatment methods?
Yeah, hi, good afternoon. Thank you so much for your presentation, Lori. I really appreciated that. So I'm a health educator for Michigan State University Extension, and this is just kind of a topic area that I'm interested in and bringing, you know, more information to our organization and to the public that we serve about eating disorders. And so with orthorexia nervosa, it's not in the DSM-5 yet. It's not classified as an eating disorder alongside anorexia. I've been reading some research of how it's somewhat related to anorexia nervosa, but also like OCD. And so I was just wondering, like, clinically speaking, are we seeing any move toward it becoming, you know, a diagnosed condition as part of the DSM, or you know, is there seeing increase in prevalence rates? What does the monitoring look like for it? Just what you're seeing as a professional.
Again, you know, I think it's underreported. Orthorexia is also very accepted in our society. Orthorexia, you can look at many athletes and ask them for their 24-hour food recall and what their exercise routine is, what their feelings and thoughts are about food, what their rules are about food. And you can quickly see that there's orthorexia there. But we can easily assess that person with a diagnosis of orthorexia, but we can also put them under the OSFED category. With more, we have a comprehensive assessment, we can uncover a little bit more, and it's very likely that a person I'm not going to say a blanket statement, but many people that I've seen in the past 10 years who have orthorexia, they also have anorexia, and they also have bulimia nervosa. You think about the overexercising component of the compensatory behaviors in bulimia nervosa. That's one that is often seen in orthorexia. So what I'm seeing is that, you know, we're treating more and more a combination of eating disorders with mental health diagnoses as well. So I think, you know, again, it's a conversation that we have to keep having. I love that you are an educator of these major issues, because the more we get out there, the more we get the state of Michigan to recognize this, maybe we can get more funding for research. Maybe we can get more acceptance of this diagnosis as being a real diagnosis.
Carly, would you like to ask your next question on food allergies?
Yeah, sure. Sorry, I had a lot of questions here today. Like I said, topic area of interest. But you had talked about how having type 1 diabetes can kind of lead to the development of an eating disorder, just because folks are being told, you know, that they already have to restrict their diet. So I was wondering if you'd see similar trends with someone that has a severe food allergy, or had a gut-related disease like celiac disease, where they're avoiding like all gluten, something of that nature.
Yes. And so that's where the biological influencer comes in. We have many people that come in with an eating disorder that started out as a gut issue. And some of those people that get formal food allergy diagnoses, you know, it's real, and we have to work around that. But not all GI doctors really know how to screen for an eating disorder. And sometimes they go over to that it is a gut issue, it is a food allergy, without testing formally for the food allergy. And then they put them on these GI diets, which then, you know, you've got somebody that, you know, when they eat something, they get terrible stomach pain. They might not be able to keep it down. They become afraid of foods. So they follow these diets, and then they become more and more and more afraid of foods. I have one case in particular that I can remember not long ago, came in with terrible gut issues, said she had food allergies, but no formal diagnosis. We did the allergy testing on her. By the time she went through our program, she was probably with us for about 8 months. She never thought that she would be able to eat anything but broccoli and chicken the rest of her life. And within 6 months of her leaving us and getting back into school and back into her work, she was traveling to India, which was her dream, and being able to eat Indian food, which she could not tolerate. But it took us medically really doing all the right tests for her while helping her change her views, confirming whether or not they had food allergies or not, which she didn't end up having any. But we actually have a staff member, an eating disorder specialist, who has, why is it escaping my mind? It's celiac. And, you know, we are able to work around that. So, I mean, we're not going to give her gluten because her body can't handle it. But there's other ways, you know, and it doesn't have to lead to an eating disorder, but it often does. Very, very complex. That's why we have to look at the whole person as well. Always go back to the iceberg. We've got to get all the information.
So we have another question. Do gender nonconforming or transgender individuals have a higher rate of ED than the general population?
They have an increase, their rate is increasing, yes, and they do have a higher rate. And I don't mean to make that sound contradictory, but we're getting more and more information. And that is something that's very near and dear to my heart as well. And it's a complex issue, and again, it requires us to be very thoughtful and kind and understanding. It's just, the way I would equate it is when we take someone where they are, and are helping them through a process of becoming who they are wholly, making them whole, and they have an eating disorder, it's very, very difficult. You can imagine that if I identify as a male and I have a female body, how especially my body is growing and developing, how that would affect me, and why I might turn to an eating disorder behavior because I want a more lean masculine body, and I don't have that. So what can I do right now to help myself have more, you know, be closer to that? You know, and it's a very complex thing. I am not that expert, but I align myself with the experts and I'm learning from them. It's very similar to male identified, biologically male clients with an eating disorder, where their restriction and food patterns are based on a completely different body ideal than maybe a female has. So they're looking at a, you know, bigger muscles, a bigger body type, more muscle development. And what do they have to do in order to achieve that ideal body type that they have in their mind? And so their eating disorder behaviors are much different, but they're still eating disorders. So when you asked about the orthorexia, that's kind of what I'm pointing to. You're doing extreme food rituals and you have extreme food rules and patterns and behaviors around achieving that, whether or not you have the ability to look like that or not.
So Tracy is asking, could we run through some of Lori's recommended resources again?
Yeah, and you're going to get a copy of my PowerPoint that you can have. So I would go if you are considering doing a very general pre-screen on one of your clients, you can go to the general pre-screen that's on the National Eating Disorder Association website. But it's a very basic one, but it can point you in the right direction. And I'm always a resource to you to help you find professionals in your community that can work with you and your client. Thank you all. And, you know, I'm always available. My email, I think I put my phone number in it, but Kristen, I think you have my phone number. You are welcome to my phone number. You have a question, you want to collaborate on something. I just want to get the word out. And, you know, I always say, especially when I do my trauma presentation, we need each other. I'm not the expert at everything. You know, there are people that do a lot better work than I do, but we can do it together. And I just hope we can somehow spread the word, especially among our young people, all of the things they can do to help themselves rather than harm themselves. So I wish you a wonderful weekend. Thank you for having me, Kristen. This was
Thank
really
you,
nice.
Lori. Yes, thank you for being here.